All right, good morning. Well, good afternoon, everyone. I am Dr. Charlene Brown from Learn Care Together, and I'm excited to welcome you to the fourth in the Maryland Emergency Preparedness Network's 2020 COVID-19 webinar series. Today, we are thrilled to have Dr. Cliff Mitchell from the Environmental Health Bureau of the Maryland Department of Health talk to us about COVID-19 and chronic conditions at home, looking through two lenses. Again, I'm Dr. Charlene Brown, but in order to introduce the Maryland Department of Health and introduce Office of Preparedness and Response, I'm turning it over to Dawn Seek from the Maryland National Capital Home Care Association.
Thank you, Charlene. Welcome, everybody. We're really happy to have you on this broadcast today. I would like to let you know a little bit about MNCA. MNCA is the Maryland National Capital Home Care Association, and we're a trade association for home health, home care private duty, and durable medical equipment providers in Maryland and DC. This presentation series is brought to you through an award that MNCA has received from the Maryland Department of Health Office of Preparedness and Response. We maintain an emergency preparedness website geared toward home care. There's useful information and materials which is free for you to download, and you can also sign up to get our emails that come out whenever there's an emergency that needs to be addressed to give you time to prepare for your patients and yourselves. There's also a tab for COVID-19 information on that website as well, so please feel free to share that. Also, please visit both the MNCA and the Emergency Preparedness website. For those home care agencies who are not familiar with MNCA or are not members, please check us out. If you have any questions at all, you can please feel free to email me. My email is right there, dc@mnca.org, and I'll be happy to answer any questions that you have. I want to let you know a little bit about a few of the upcoming Emergency Preparedness Network webinars we have. On August 19th, we have Barbara Citarella. She is a very well-known home care expert in the area of emergency preparedness, and she's going to talk to us about COVID compliance audits and after-action reports, especially for the home health world. That is very important. It's part of their conditions of participation. And then on August 20th, where Dr. Beth Galick, who is a professor at the University of Maryland, is going to talk to us about dementia symptoms, assessment and management under lockdown. And then we have some other events coming up later in the year, so please continue to check the website because we're adding new information all the time. So thank you again for being here, and I'm going to turn it right back over to Charlene.
Wonderful, thank you, Dawn. Now it's time for the main event. I'm very pleased to introduce Dr. Clifford Mitchell, Director of Environmental Health Bureau in the Prevention and Health Promotion Administration of the Maryland Department of Health. He is a phenomenal, wise gentleman who I've had the chance to get to know a little bit in planning for this presentation. He oversees a number of public health projects in the Bureau, including giving weekly COVID-19 updates. And that's because he's the Bureau's, well, the department's lead for COVID-19 and different parts of the business sector, which includes most of you. Dr. Mitchell joined the health department in 2006 after many years in the faculty at Hopkins School of Public Health. His expertise is broad. It ranges from home visiting programs for children with asthma, a range of environmental health leadership roles and advisory committees at a national level, and he has quite a long list of peer-reviewed publications and reports. He received his medical degree from Case Western Reserve University, his MPH, again from Hopkins, and his master's in science from MIT. I'm so pleased that Dr. Mitchell is going to provide us with some updates on COVID-19 from the Department of Health and his vision for looking through two lenses to understand COVID-19 and chronic diseases in the home. Dr. Mitchell, take it away.
Okay, thanks, Charlene. So if you can give me a screen, I will go ahead and present slides.
Just go ahead and hit share.
Fabulous. Okay, very good. Yes, I'm going to stop your screen sharing and do that. and that, and just let me know if you are in fact seeing the slides.
They're stunning.
Okay, well, stunning is probably all I could hope for at this point. Let me see if I can go into presentation mode. Okay, now you should see the presentation. And thank you very much, Dr. Brown and Ms. Seek and guests. It's a delight to be here with all of you today. And I want to talk to you a little bit about COVID-19, as Charlene indicated. So a couple of things about me that are relevant to this presentation. The first is, as Charlene indicated, I've been both on the academic side at Hopkins in the Department of Environmental Health Sciences, and more recently here in the Department of Health since 2006, primarily interested in public health practice, both from the point of view of internal medicine, which is part of my training, and occupational and environmental medicine, which is mainly what I've been doing for the past years. And it's really with a sense of gratitude that I come to this position, because it's afforded me an opportunity to work with a really, really good group of public health professionals in the Department of Health on a variety of issues, ranging from H1N1 in 2009 through a variety of other emergencies. I spend a great deal of time working on chemical, biological, radiological issues as well. And part of the sort of challenge of this is the Environmental Health Bureau, which does cover primarily food protection for the state, as well as environmental, occupational, and injury epidemiology, and a variety of prevention-related programs, including some of you may be familiar with our certification programs. If you have children who have been in summer camp and youth camps, our Bureau is the one that regulates and certifies licensed youth camps. We also license and certify swimming pools and other aquatic venues. So we do a large variety of environmental health activities, and work very closely with our infectious disease colleagues on a whole host of complex issues. And so with the advent of COVID-19, obviously, we are all in the department, everyone now, engaged in this response to the worldwide pandemic. And really, our role in the Bureau is to support our infectious disease colleagues. But as you know, there are many questions that have come up regarding COVID-19 that pertain to environmental and occupational issues. And I've been working on those with our team to help provide guidance to businesses, to higher education institutions, schools, and others about how to think about COVID-19 and COVID-19 response. And it is through those two lenses that I want to speak to you today. It's really about how do you think about COVID-19, both from an infectious disease and internal medicine perspective, and you as home health people, how do you think about your patients in that regard? But equally, I want to share with you some thoughts about how you think about the occupational medicine aspects of COVID-19, which is to say you as managers, as workers, also have exposures. And you may or may not be familiar with the fact that occupational medicine, environmental medicine, and infectious disease slash internal medicine have often had somewhat different perspectives with respect to issues related to all kinds of infectious diseases. And it is so it is with that that I hope to talk to you about these the current sort of epidemiology of COVID-19, as well as our state activities, and then also looking more specifically at home health care with respect to several sort of exemplary conditions that are some of the most prevalent conditions that you all deal with in people who are at home receiving home health care. So let me start off with the epidemiology, and none of this will be a surprise to you. If you look at worldwide, you should know, unless you've been living in a closet for the past, and face it, many of us have been living in a closet, at least physically speaking. But if you've been living in a closet and also not reading the news at all, you may be unaware of the fact that there's a worldwide pandemic of COVID-19. Every continent has been affected. I believe there has actually been a case in Antarctica. I'm not absolutely 100% sure of that, but every other continent has been affected. You know that the United States has been, is at this point, the most affected country in terms of cases. We'll talk about that in a minute. But worldwide, as of yesterday, we have more than 20 million cases across the globe. We are coming up on 1 million deaths, and many, many more hospitalizations. And at this point, even countries that have very successfully conducted lockdowns and abated their cases have seen wavelets or resurgences over time, indicating that this is a virus that is circulating widely in the environment. It's the result of having a lot of hosts, i.e. people. And if you look at how many people have been infected and how many people are potentially exposed, or yet, that is to say, susceptible. So in infectious disease models, you know, we specifically and generally talk about a sort of 3-compartment model of disease. One is the susceptible population, people who have not been exposed. One is the population of people who are ill, and then the other is the population of people who have recovered or died. And that 3-compartment model, the sort of SIR model of susceptible, infected, and recovered, is typically the way most models work for infectious disease. And as you know, if you've looked at any of the modeled projections of COVID-19, which are based primarily on influenza models, you know that, excuse me, we have a very large pool of still susceptible people across the globe. People have been looking using antibody testing to look at how many people might still be naive, that is to say, susceptible, because they lack antibodies and are not actively ill. So it looks like they haven't recovered or haven't been exposed yet. And as far as we can tell from prevalent studies of antibody across the globe, we have yet to infect a very significant minority even of people on the planet. So you've probably seen that In some cases, in some areas, we may have infected up to maybe half of the population. That still leaves half of the population that has not been exposed as yet. And in the United States, although we do not have systematic data on antibody status across the nation, studies in New York and in California and in Washington suggest that even in areas where there's been a lot of disease up to now, say, for example, the New York, New Jersey area, if you look at the amount of antibodies in convenience samples that could potentially represent the general population, we're still talking about antibodies being detected in well under 10% of the population, more like 5% at most of the population, maybe up to 15% in a few exceptional areas. But it still means that we are very early in this pandemic, really early, because most people have not been exposed and are therefore, because there's no natural immunity to this disease, it means that most people are in fact potentially susceptible to this infection and could be infected at some point in the future. So what we have seen to date is a very, very, very small fraction of what this disease could potentially represent in terms of number of people infected and number of people ill. So with that somewhat sobering thought, let's look at the United States. So in the United States, as of yesterday, we have over 5 million total cases diagnosed. Now, those are laboratory confirmed cases, and if you recall, we know that, in fact, most people will not have been tested who are symptomatic. Many people more are probably infected than we show here. So it is quite likely that the actual number of cases in the United States is much, much higher than the 5 million that we have diagnosed. We've had 163,000 plus deaths as of yesterday. And unfortunately, as you know, our number of deaths and our death rates are significantly higher than many other countries. And we're not going to talk about the reasons for that because they have been extensively reported in many locations. But we still have a lot of work to do if we're going to bring this disease under control. And we are not at this point able to say with any degree of confidence that we have achieved control of COVID-19 in the United States. Now, if you look at this map, what you can see is that we do have, as you all know, a surge of cases in the West and Southwest. In many people's minds, that has been associated with reopening early and a lot of loss of some of the key controls for COVID transmission, which include social distancing, facial masking, hand and cough hygiene, and frequent hand washing, as well as very effective removal from work when people are even mildly symptomatic, and an aggressive testing platform for people who are symptomatic to identify both people who are ill and to test people who are close contacts of people who are ill or who have been diagnosed with COVID-19. And we'll talk more about that when we get to the state response. Now, if you look at Maryland, and we'll talk more about Maryland in a minute, you'll see that Maryland is in the swath of states that is not by any means lowest in terms of infection, but one of the things that Maryland has done under Governor Hogan's leadership, and really with the really active participation of many Marylanders every single day. We have managed, if you look at the test positivity curve in the lower left-hand corner, we have very successfully done several things to improve our control of COVID-19. Now, you know that the federal government has identified several benchmarks for states to sort of think about. One is testing a certain percentage of its population, 10% of its population, as a sort of a benchmark or mile marker. One is a positivity rate of under 5%. I want to say a word about these benchmarks because they reflect one way of thinking about how we're doing, both in absolute terms and relative to other states and jurisdictions. Excuse me, one of the questions that has been raised a lot in the media is, which of these is the most important? New York uses a different benchmark for its determination of who needs to quarantine when people come in. They look at the case rate as determined by the number of positive cases per 100,000 people in the population. There are other benchmarks that people have suggested using. So the question that often gets raised is, what's the best benchmark? And I just want to say, although the governor is the person who makes decisions, and he has had a lot of advice, he has academic and expert physicians and public health people and others from the business community and elsewhere who advise. But at the end of the day, one of the things that the Hogan administration has done is it has looked at a large volume of data, not just one point, and not just one data point, but a slew of data points in order to best understand when it's appropriate to take different actions. So people frequently ask, when do we get to phase 3? Or, what are the criteria for going to phase 3? Or why did you decide to stop and take a pause in phase 2 of the roadmap to recovery? And again, this is the governor's decision, but one thing I can say with confidence is that to now, and I expect in the future, decisions about this are going to be based on data, and they're going to be based on a large sort of range of data because this is a complex disease that affects every segment of society. And there are things in here that even with the data that I'm showing here, there are other issues that we look at that are not reflected in these data. For example, we have noted in recent weeks that the positivity rate, the number of tests that are positive compared with the total volume of tests done, has been significantly higher for people under 35 than for people 35 and over. At one point, a couple of weeks ago, the positivity rate for those under 35 was actually double or almost double the positivity rate for people 35 and over. Now, if you looked at the early part of the pandemic in Maryland, what was striking in this early portion that was from March to about mid-April, was that the positivity rate was higher for people 35 and over, and the biggest volume of the biggest number of cases, biggest percentage of cases came from the national capital region. So you may be aware of the fact that in the last several weeks, that has changed. There is still a predominance of women over men who are infected. It is also true generally that men have more severe disease on average, probably because of comorbidities, but that's, there's a lot of speculation about that. But in terms of the demographics here in Maryland, we have seen a noticeable shift with now the largest percentage of cases coming from the central Maryland region of Baltimore City, Baltimore County. And we've seen a decided shift to younger cases, where the positivity rate for young people, that is to say people under the age of 35, has been approaching 6 or more than 6%, whereas in the 35 and over population, it has declined to 3%. And so it's really half in some sense, or almost half, or a little more than half, depending upon when you're talking about, of the rate for people under 35. This question about looking at the sort of nuances of the data is really, really important, because only if you understand the nuances of the data do you understand why it's important not to sort of think about a single metric. So for example, we have observed, and we continue to observe, that there are significant disparities between different racial and ethnic groups with respect to both the severity of disease and with respect to the issue of questions related to likelihood of infection. So, for example, we do know that people who are Spanish-speaking, who are non-white and white Hispanic individuals, have a higher likelihood of infection. Not necessarily more severe disease, but a higher rate of infection than other racial and ethnic groups. And we also know that people who are Black non-Hispanic have tend to have more severe disease. And so these differences are very important when understanding what kind of preventive actions to take and where to focus the preventive actions. And for people who are engaged in home health, this can be important in terms of thinking about the demographics of your individual patients. But it's also important in terms of thinking about the difference between sort of the community spread and the spread associated with other risk factors. So that's a picture of sort of where we are in the epidemiology of the disease. And I want to turn now to issues related to more our preventive interventions. So as you know, we have vastly expanded testing availability across the state. We now have more than 200 sites where people can get tested, including hospitals, including pharmacies that have implemented testing, the Vehicle Emission Inspection Program, the VEIP sites that the state runs. County jurisdictions have done testing in different locations in order to access communities that have not necessarily had a lot of testing. And our volume of testing is now routinely above 20,000 tests a day. You know, that testing is one leg of the response. It's a very important leg because without testing, we don't know who's infected, but it is not sufficient in and of itself to control the spread of disease. It has to be linked very closely to contact tracing. So I don't know how many of you have personally been involved in contact tracing, but when somebody gets a test and is identified as a case, a laboratory report, the results of that test are sent to the state, to the Chesapeake Regional Information System for Our Patients, or CRISP. And from there, it goes both to our local health departments, the state health department, and to it also goes into and is accessible through COVID Link, which is the platform, the electronic database and data management platform that the state is using with a contractor to make sure that we quickly contact people who are identified through laboratory testing as positive, contact them, call them as quickly as possible, find out and notify them and make sure that they are home isolating for the requisite period of time, and also interviews them about close contacts. And those close contacts may be at work. They are certainly household members who may be close contacts. And the scripts and data management platform use that information to gain a better understanding of the epidemiology of the disease, to quickly notify people to quarantine themselves if they've been exposed and could potentially develop COVID-19. And it also, along with other efforts, allows us to, again, try to access those difficult to reach but really important populations that need to be tested, particularly contacts of people who have been identified as positive. Those two legs are two of the four legs or pillars in the roadmap to recovery. The other two are surge planning, and you all know probably that the department and the state have set up a large number of surge facilities at hospitals across the state, as well as other institutions, the correctional institutions and some others, to be able to handle an increase in cases. And as you may recall, when this started, we were planning for a considerable surge thanks to the efforts of Marylanders, and under the leadership of the governor, we did not exceed our capacity. But we think if the models hold true, there is at least a possibility of a larger second wave of illness that could occur, similar to what is being observed in other countries. And we are continuing to do our surge planning to be sure that we have adequate capacity should that happen. And then the final leg of the, or the final pillar of the roadmap is personal protective equipment, which is part of infection prevention and outreach. And that's part of what I spend my time doing, but the department has, both through the private market and through federal assets, stored a great deal of, acquired and stored a great deal of personal protective equipment, and pushed it out to local health departments and governments and others, so that we have adequate PPE where it's needed. So what I want to do now is sort of pivot and talk about these two lenses that I mentioned, the sort of occupational medicine and the internal medicine lenses, to sort of think about home health as a unique workplace, and your role in it, as well as, you know, how you interact with your patients. So let's start with some pathophysiology related to COVID-19. As I'm sure I don't need to tell you, COVID-19 is sort of a protean illness which has many, many manifestations. And from a pathophysiology point of view, we have observed that the primary illness is clearly respiratory. But this is really a systemic disease with a wide variety of clinical manifestations. And they can be respiratory, they can be neurologic, they can be multi-system, they can be hematologic, including blood clotting abnormalities. They can be as simple as fatigue and a runny nose, or as complicated as the multi-system inflammatory syndrome that children develop. And so the question that you face in dealing with patients who are already medically compromised is, what does COVID-19 look like in your patients if they should be exposed to COVID-19? And also, how do you protect yourself from COVID-19 while working with them? And what is the interplay between people with chronic medical conditions and COVID-19? And I'll tell you that in sort of thinking about this, as I mentioned, I tried to take a look both from an infectious disease perspective and from an occupational medicine perspective, because they are somewhat different. One is looking at the sort of infection prevention model, and the other is looking at a workplace engineering PPE model to understand best how to protect both your patients and yourselves during this time. So we're going to look at what is known about coronary artery disease, diabetes, and chronic obstructive pulmonary disease as three different models of chronic illnesses that are illnesses that you all deal with on a regular basis in the context of COVID-19, and think a little bit about what we know about that interplay that can and should help guide your management and approach, your management of and approach to being in a home situation with somebody with one of those conditions. So let's start with coronary artery disease. If I could spell independent, I would probably have another E in there. So the one thing we know about coronary artery disease is that it significantly increases the risk of mortality. So if you have people with pre-existing coronary artery disease, that significantly increases the risk of mortality according to systematic reviews of people who become infected with COVID-19. The odds ratio is pretty high. An odds ratio, OR, simply means the risk of death if you have COVID-19 and coronary artery disease versus the risk of death if you have COVID-19 but not coronary artery disease. So as you can see from at least this one study, and all of these are relatively recent studies for obvious reasons, there's almost a four-fold increased risk of death associated with having pre-existing coronary artery disease if you develop COVID-19. Hypertension is itself an independent risk factor. So because many people with coronary artery disease have hypertension, it's difficult to tease out, but it appears even if you have hypertension alone, your risk of death increases. But if you have hypertension and coronary artery disease, that does increase your risk. Now, the question to ask is, what if you've got somebody with congestive heart failure or significant coronary artery disease? How do you think about COVID-19? So obviously, from an infectious disease point of view and a prevention point of view, which is also the occupational medicine point of view, your approach to the person with coronary artery disease is, with respect to COVID-19, the same as everybody else, which is that you really want to emphasize, and do emphasize, the importance of not getting exposed to COVID-19, which means people who are ordinarily homebound, they're not getting out and about, so that's actually a good thing. If they have to go into the hospital, that's obviously a concern. And keeping people out of the hospital, because there is a lot of COVID-19 in the hospital, there are now additional benefits to keeping people out of the hospital because it does increase the risk of exposure. And we know that is true. We also know it is true in skilled nursing facilities and assisted living facilities, that there can be a significant amount of asymptomatic COVID-19 in any facility, which is the reason that facilities are now routinely being tested. And so people who are able to be at home have a significant, I think, advantage compared with people who are in an institutional setting. And the importance, therefore, of home health care in that context cannot be overestimated. It's really incredibly valuable and useful to be able to keep people in a home setting where, frankly, their risk of exposure is probably less in many instances than it would be in a congregate living facility like a nursing home. Now, with diabetes is itself a multi-system disease, as you know. And so what do we know about diabetes and COVID-19? Well, it turns out that we don't know a lot. And that's true of all of these conditions, is that because COVID-19 is relatively new, we don't, for example, know what is the mechanism by which COVID-19 may have an increasing severity in people with diabetes. Certainly, diabetes affects the inflammatory response and is itself activates inflammatory markers, as you know, and therefore having COVID-19 coexist with the diabetes means an increasing risk of complications given both. But the mechanism of damage to that may be very, very complicated. There is some suggestion in the literature that people who have no diabetes may be at increased risk of developing diabetes because it appears that the ACE2, the angiotensin convert enzyme 2 receptor, which is present in the pancreas, in pancreatic cells, may actually be a mechanism of entry for the virus into pancreatic cells and could lead to pancreatic damage. So there is some question about whether or not COVID itself is a risk factor for the development of type 2 diabetes. There's a great deal of emphasis, although I was unable to find any systematic guidelines in the US. A number of European countries have developed guidelines or suggested guidelines for COVID-19 and diabetes management in the home. And part of that includes the use of insulin in preference to, for example, metformin. And part of the thinking about that is that being able to do really good glycemic control with short-acting agents prevents the possibility or reduces the possibility of ketoacidosis or complications due to longer acting stabilizing controls, which in another context might be fine. But given the importance of being able to respond quickly in the event of an infection, it may be that there's some advantage to using short-acting agents. But you have to balance that with are people able to use short-acting agents? And so I think that this is an area where we're going to see the likelihood is guidelines develop over time as people better understand the relationship between the connection between this condition and COVID-19.
Dr. Mitchell?
Yes.
Hi, this is Charlene. I'm just jumping in to let you know that we are going to shift over. I know that you're not done.
Yep.
But it's 12:47.
And I'm just about done.
Excellent. I saw you had one more slide.
Yep.
But for everyone that's listening, the last slide is on COPD. Why don't you go ahead and shift over to it?
Yep. No, that's perfect.
So if you guys have any questions about COPD, we can add them into the Q&A, but I wanted to make sure that we had a chance for the audience to ask questions.
Yep, and that was my timing was almost on the mark. But yes, so COPD, what I can tell you is it is clearly a risk factor for more severe disease and for higher mortality. But again, the mechanisms have yet to be elucidated, and management guidelines specific to COVID-19 primarily are related to not getting COVID-19. So with that, I've included some references, and Charlene, you are now on questions.
Fantastic. All right, thank you, Dr. Mitchell. So let's start with the first question. And for the audience, Dr. Mitchell's talk was a wonderful overview of COVID-19 in Maryland. And I know that this network is really focused on home care and home health care. And so given the two lenses that Dr. Mitchell was focused on, I invite you to ask any questions that you have through the lens of home care and home health care. So let's start with a question from Deborah Jackson. Deborah is asking, she says, there is talk regarding numerous trial vaccines. Most recently on the news, there was mention of the possibility of the need for a special strain of the vaccine for African Americans and Latinos. This was referenced in light of the comorbidities. Could you please address how different the process for creating such a vaccine would look, and would there be an option for those of color without comorbidities choosing a different vaccine? So Dr. Mitchell, do you feel like speaking to these vaccine-related questions is within your expertise?
I'm happy to say that my answer to that question would be as well informed as yours, as the questioners. That there is, we're very early days on vaccines. And what I can say is that one of the reasons that everybody's looking askance at Russia is nobody understands the performance of a vaccine at this point until you've done trials in a wide number of people. So until we have those data from those different groups, we will not know whether or not any particular vaccine confers differential protection in different populations. And so we have to wait for the trials.
Okay, great. And Dr. Mitchell, I so enjoyed your review before. I invite you to start your video so everyone can see you as you're answering the questions.
Oh, that's, I was trying to be nice about that.
No.
All right.
I think we all want to see the beautiful trees. So for anyone else that has questions, please include them in the Q&A section at the bottom of your screen. We'll go ahead and ask Dr. Mitchell about contact tracing. So in the context of home care agencies and home health agencies that are sending caregivers to work directly one-on-one in intimate spaces with people in their homes, what is the Department of Health, or what do you anticipate the future of and expectations for contact tracing in this industry? How should agencies start thinking about it, and how should they prepare?
It's a very good question, and we face it with a large number of employers because most contact tracing focuses on the readily identified contacts that occur primarily in households. So we have been asked and provided guidance to a significant number of people related to issues on the role of the workplace and the employer with respect to contact tracing. And we're sort of developing a nuanced approach to this in which employers probably need to start thinking about something that is not quite full-blown contact tracing, but more contact identification in the workplace. And the goal here would be that when the local health department contacts an individual and that individual works in a particular industry, we will contact the employer in some cases if there appear to be multiple people associated with an outbreak in a setting. But in home healthcare, it's going to be very difficult to identify that. So I think, excuse me, what we are going to do is, and what we have done is urge employers to look at their experience and think about contact identification where you can follow your staff closely in terms of where they're working, understand where they have been and with whom. The likelihood is that if we have a situation where people are working at home with somebody who has been diagnosed through laboratory testing with COVID-19, when the contact tracer calls that individual who's a client or a patient, we anticipate we will hear or may hear about home healthcare providers as potentially close contacts. Recall that close contacts defined by the CDC change depending upon whether you're using full hospital PPE or whether you are, and this goes to Kim's question too, depending upon what kind of PPE you're wearing, close contact, certainly less than 6 feet for more than 15 minutes or 15 minutes or more. If you are wearing a combination of an N95 respirator, a face shield, a full face shield, and a gown, you are well protected against COVID-19. I would say that there's emerging science, which I think is probably accurate, that there's a small fraction of infection which may be related not to large droplets, but to fine aerosols that are particles in the air floating. And so there's probably airborne transmission limited as well. So I personally recommend in situations if you have somebody who has been diagnosed with COVID-19, using the same kind of PPE that would be used in a healthcare setting. N95 with a mask to protect your eyes because the eyes are a route of exposure. And if there's droplets, certainly a gown.
Thank you, Dr. Mitchell. That is very consonant with what our speaker from a few weeks ago who did a talk on PPE also said about what is recommended in terms of PPE precautions, what to wear in terms of PPE when taking care of clients in the home. There's another question from Mark Finley.
Yep.
There is a significant amount of anxiety and increased risk factors to the elderly. What we need are rapid test sites for caregivers because caregivers want to be tested recently. This might be more of a comment.
Yeah.
But specifically, could you talk about the
rapid testing?
Yeah.
Yeah, so this is an area which has seen a tremendous amount of discussion and interest over the past several weeks. You may have seen the governor's initiative with other states to try to promote rapid testing by pushing the industry. It's a very complex issue. Rapid tests have been developed both on the basis of molecular testing and antigen testing. So some of them work by detecting the antigen itself, the virus itself. Some of them work by detecting, looking at RNA fragments. They have very varying degrees of test performance. Most of them have been developed to be used in the clinical setting of symptomatic individuals where you clearly want to you have symptoms and you want to be able to quickly judge whether somebody is ill from COVID-19 or something else. There is not a lot of experience with these tests using them in the context of large-scale screening of asymptomatic people. And it is very important to understand the specifics of the test characteristics, their sensitivity, specificity, positive predictive value, and negative predictive value, which depend very much on the prevalence of disease in the particular population where the testing is going on. So, and rapid test, in terms of how rapid that means, generally speaking, most of these tests do take about 15 minutes to run. So they're not rapid tests. And in addition, some of them actually come with a stipulation under their what's called their EUA, their use authority, that they should be viewed as presumptive and followed up with a laboratory-based test like RT-PCR for the virus. So I guess, Mr. Finley, what I would say is these tests they're not a panacea. They are complex. They have to be done in carefully controlled settings where by competent technicians. We don't have a lot of experience with them in a sort of a large mass setting in asymptomatic individuals. So I think a lot of this is evolving and we will see it evolve over time.
Just to piggyback on Dr. Mitchell's comments, any kind of COVID test that is testing for the presence of viral particles is going to have, when he talks about sensitivity, he's talking about the ability of the test to detect disease. And so there will be people who have negative tests who actually could be COVID positive, but it's not picked up by the test. And so these tests, the rapid tests, their sensitivity is the regular tests that you would get at a testing site don't have excellent, they have good, but not excellent sensitivity. But these tests, their sensitivity might be even lower. Was that part of what you're trying to communicate? The risk of false negatives and false
yeah, so it's both sensitivity and specificity. So you're quite right. If you're positive, if you are actually infected, depending upon the day that you're tested relative to when you became infected and your viral load, you can, it is quite possible to have a test that says you're negative even though you're infected. And by the same token, if you're actually not infected, there is also the ability to show that definitively that you are not infected is not 100% either. There are cases where people are identified as infected who are actually not infected.
There you go. There's no panacea. It's 12:59. Let's see if we have any other questions, and we'll run a little bit over if anyone wants to stay on. But Dr. Mitchell, you talked about COPD, coronary artery disease, and diabetes, and people who may be at higher risk of COVID if they get infected with COVID. Many of the caregivers that deliver care in home care are older adults themselves.
Yep.
Who also have coronary artery disease, diabetes, COPD,
yep,
as well as myriad other conditions that may put them at risk of more serious disease if they get infected.
Yep.
How should home care agencies be thinking about the risk of not only the clients in their care, who are mostly, in many cases, older adults, but also the risk and safety of their workforce?
Well, and that is the occupational medicine question, which is how do you protect workers? Because the truth is, as the American workforce ages, that's true for everybody in all industries, not just for home healthcare, but in home healthcare, it is certainly true. The answer to that question is good workplace controls, meaning good personal protective equipment, good work practices, certainly having a very good sense of who your employees are and making sure that they are equipped with both knowledge and the tools that they need. And there may be some circumstances where if risk is significantly elevated, people actually use administrative controls like reassignment to ensure that, for example, if they know they have COVID positive patients, people with significant risk factors may be reassigned to other clients to avoid exposures. But that's, those are all tools that are standard occupational medicine tools, and they work as effectively here as they work in other contexts.
All right, thank you. Thank you to the audience for these great questions. I'm gonna go ahead and help us transition to the final slides. Dr. Mitchell, your responses were excellent and your presentation was very helpful. We just wanted to do another shout out to the Emergency Preparedness Network, MINCA, and my company Learn Care Together. And thank you all for joining us. And thank you to all of the various stakeholders that made today possible. Dr. Mitchell, not only is the Maryland Department of Health a sponsor of the talks, but you are a speaker and a wonderful speaker at that. So thank you again for your time. Thank you everyone for coming, and don't forget to register for the upcoming webinars. Have a good day, everybody.